Hello, hi, I'm Dr. Omar Bey, and welcome to our Physicians Health Network, all righty. And basically, we're just so happy to be here today. Let you know that we're a group of Black physicians that are dedicated to do several things, and there are two major things that we do. Number one, we try to improve health in the African American community. And number two, our goal is to let young Black men know that they can be doctors and that it's possible. And we would like to know if we could help in any way as far as mentoring is concerned. That's so important for our community. Understand that our webinar is every second Saturday at 1 o'clock. And all you have to do is go to OBHealthy, that is O, the letter B, and healthy. Click that website and go to the bridge where it says Physicians Network, and you click that and it will let you into the webinar. And we look forward to answering each and every one of your questions, all righty? If you missed the webinar, you can go to the our YouTube channel under OBHealthy, either through the website or go right to YouTube, OBHealthy, and you can see all of the past webinars. They're all great information, all right? Remember to subscribe because we want to continue to stay on YouTube. And I just want to say again that type in your questions, all righty? And we look forward to answering all of your medical questions. Okay, I'm going to say this because I feel this is the most important thing that I can say today. Do not change any aspect of your medical care until you consult your physician. This is so important because what we're talking about is only your doctor really knows how to best care for you. So do not change any aspect of your medical care, no matter what we say, until you consult your physician. Our guest specialty today is ophthalmology, and that's the eye. And we have a brother that's here today, Dr. Bobby Cunningham, and he will answer all eye questions. So if you have an eye question, or if you know someone that has trouble with their eyes, please tell them, call them, let them know that they should sign on to OBHealthy and come in and ask their medical question today because he's here. And we want to take care of all of that, all righty? What I'd like to do is, I'd like to get started. And first, what we're going to do is allow each of our physicians to introduce themselves. I'm going to use the order that's on my screen, okay? And it starts with Dr. Kevin Clark. Kevin, could you unmute yourself? And we will start with you and introduce.
Sure. Good afternoon. Thanks for having me. I'm Dr. Kevin Clark. I'm a surgical oncologist. I work at Newark Beth Israel with most of these gentlemen here at the panel. Good to be.
Yes, thank you. Dr. Salam.
Good afternoon, everyone. My name is Dr. Kareem Salam. I'm a board certified adult and child and adolescent psychiatrist, and I work out of a hospital in the city of brotherly love and sisterly affection, more commonly known as Philadelphia. I'm on the faculty of Drexel University College of Medicine, and I'm a founding member of Global Health Psychiatry. We're an organization that publishes mental health literature focused on the Black community to address stigma. Thank you so much.
Excellent, excellent. Dr. Kendall Sprott. Ken, you're muted, Ken.
I'm Kendall Sprott. I'm a pediatrician who specialized in critical care pediatrics and general pediatrics, and I'm currently retired for 1 week.
Hey. All righty, Dr. James Lee.
Good afternoon, Dr. James Lee Jr. I'm a legacy board certified orthopedic surgeon based in Essex County, New Jersey.
Excellent, excellent. Dr. Nelson Aluya, please. Dr. Aluya, you're muted.
Yes, hi, good afternoon, everybody. Nelson Aluya, medicine pediatrics trained, assistant professor at New Jersey Medical School here in Newark, New Jersey. Also, I call myself a medical advocate. I'm also attending at the Newark Beth Israel Medical Center, where I work with a lot of these great and amazing doctors. Thank you. Glad to be here.
All righty, thank you. Dr. Lawrence Daniels, please.
Thank you. So my name is Lawrence Daniels. I'm an adult and pediatric neurosurgeon, taking care of patients in New Jersey and New York.
All right, thank you, thank you. And Dr. Robert Cunningham. But Robert, Bobby, before you start, I'd just like to say something. Number one is that this brother is, second generation ophthalmologist, but even more than that. And Bobby, I may not have told you this, but he's the reason that we're doing this today. And I want to tell you why. And just give me a moment and bear with me for a second. Dr. Cunningham asked me to come, and Bobby, I want to tell him you're a Kappa, right?
Yes, sir. Yes.
All right. So, and I just want to say that he invited me to talk to the brothers after a major meeting that they were having here for his grad chapter in West Orange. And basically, I thought about talking about prostate or hypertension, and I said, let me just let them ask their medical questions. Right. And it started about 9 o'clock, and I didn't get out of there until about midnight. And it was awesome, the questions that they had. That's the reason that I got the idea to do what we're doing today, because of Bobby Cunningham. Bobby, introduce yourself, please.
Okay. Hi, guys. Good to be here. Omar, I didn't know that story. Thanks for sharing.
Yes.
Second generation ophthalmology, grinding it like the rest of it, loving it like the rest of it. I tell my folks, we hate what we do, but we love it more than we hate it. So thanks for having me. And hopefully we can make an impact to our folks.
All right. Thank you, Bob. All right. Dr. Court, you're muted, Dr. Court.
Good now.
Yes, you're good.
Good afternoon, folks. My name is Dr. James Cord. I practice in East Orange, New Jersey. My specialty is internal medicine. I'm happy to say that the gentleman that just preceded me, we're classmates.
That's right.
We've known each other since 1976, and we still work together very closely. Bobby, welcome to our panel.
Thank you. Thank you.
What college are you classmates of?
Howard University.
Oh, is that Howard? Oh, I love it. All right, HBCU. All right, so I'm Dr. Omar Bey, pulmonary critical care and the subspecialty in nutrition, and welcome everyone already. So, the thing of it is that what I'd like to get started, and we do have some questions that have come in. The first question was about dry eyes. And Bobby, if you can help us out with this. This person stated that their eyes are frequently dry and they just don't know what to do. They've gone to their doctor and they've tried to put in different solutions, but it just doesn't seem to help. Yeah, can you give us an understanding of why the eyes would be dry and what we can do?
Right. The dry eye is a very common condition. It's very ironic because a lot of people literally tear. They're watering and tearing, and we say dry, but it's the opposite. It's a little tough to get the concept across, but what we generally do, there's not a lot to be done, short of surgery, which is rare. Usually we give lubricating eye drops 2 or 3 times a day, and for half the amount of people, that usually takes care of it. The other thing we do is a short procedure in the office where we actually help open up the tear duct plugs. It's called punctual plugs. And that keeps the tears more on the surface of the eye for lubrication. And it prevents them from going down their cheek and watering and tearing. It's really a nuisance factor. Most people do well, but putting in tears in addition to glaucoma drops or other medication drops is a hassle factor. Often punctual plugs work well, but a lot of people do have, quote, dry eyes, but they sometimes are more watering, itching, or even blurred vision. Very common and easily to treat. Mm-hmm.
All right, thanks, Bob. I'm going to go right into our questions. We got a lot coming up. It says, hello, thank you very much for your continued advice. Can you give me a advice towards a child outgrowing astigmatism? All right, can we start on this one as far as we have peds and we have psych? You're muted, Dr. Sprout. Dr. Sprout, you're muted.
Yeah, I was going to say that's also Bobby.
Right. Let me address that. Astigmatism, as you guys know, as we know, is a big word for the condition of their glasses refraction, what they actually wear. You don't feel astigmatism. You don't see astigmatism. The lines are just blurry, not nearsighted or farsighted. Astigmatism rarely gets, the only way to really treat astigmatism is glasses. Children aren't going to get surgery for astigmatism. If they have a significant astigmatism, can't see the board, can't see at night, then they're get their refraction and get their glasses. It's not a condition that hurts, that you can feel it, but it's a visual condition that needs glasses mainly, some contact lenses, not many, but astigmatism is something that is a strictly an eye disease. It doesn't cause any psychological problems that I know of. Doctors, Ken? No? No.
As you said, it is an issue related to the eye, and I'm not sure what was meant by outgrowing an astigmatism.
No such.
Yeah, what I was going to say is that, you know, I have myopia with astigmatism, which means that I'm nearsighted, which means I can see things close up without glasses, but in order to see things distance, I need to have corrective lens. But my astigmatisms haven't changed over the course of 60 some years. So I'm not so sure what she means by that, because that's, in my opinion, not very likely that it's something they're going to outgrow.
Right. I think she's probably hoping that he would, and you know, you understand. Yeah.
Right.
Okay. All righty. This is the second question comes up with. I'm just going to read.
Go on to that. Growing up as a young doctor, a young medical student.
Doctor, you're on mute.
You muted yourself, Nelson.
You muted yourself.
Sorry. No, I said growing up as a young doctor and a young medical student, astigmatism was actually, my impression then was it was a disease for old people and not necessarily for younger people. But now we begin to see astigmatism in young, individuals and stuff like that. Why is that, Dr. Cornea? And what can we do to help prevent this?
There's no prevention to astigmatism. It's really the shape of the cornea, it's the shape of the eye. It's an ocular condition that needs fixing simply by glasses. We don't outgrow it. You can't feel it. It's you're either nearsighted, farsighted, you know those terms. And the third term is astigmatism. It's really glasses correction.
So Bobby, you want to tell them what the cornea is as opposed to the lens?
Oh, right. The cornea is the front part of the eye. Think of a car, the windshield. The windshield to the car is our cornea. You can't really see it. It's protection. You can see through it. You can see inside the car, just like we can see inside the eye to see the brown eyes or the black pupils, but you can't see the windshield. You can't see the cornea. Cornea is where the contact lens sits. Although now there is surgery to correct some refractive error, some glasses issues, including astigmatism, but that surgery is usually expensive, but it can be done. Most people live with their glasses, but that's where the cornea is on the outside. Think of it, the car, like the windshield on the car. And the lens is internal. The lens is inside the eye, where the driver's seat would be. The lens turns into a cataract. So astigmatism is really at the level of the cornea on the front surface.
Dr. Salam here. I'm going to take this opportunity to highlight the importance of parents and caregivers staying on top of their kids' prescriptions, particularly their eyewear, as it applies to learning. That could have psychological impacts on youngsters if they're in the class and they can't see the board, or they're on their laptop and they can't read what's being written and what's being discussed, and the secondary effects that has on the learning process. And it similarly applies to hearing as well. So it's important to screen youngsters for visual difficulties and hearing problems.
Thank you, Dr. Salam, for bringing that up. As a matter of fact, as a pediatrician, we often see that a lot. And most people think their children are not just smart, just don't understand enough. You'd be shocked to find out that all it is they just don't see the board properly. No. So you have to take your child to get an eye exam often enough. And as kids, we do screen babies. Babies are born in before they leave the hospital, they get screened. And if there's a problem, you tend to screen them again with further enhanced screening to make sure the vision is pretty clear and they see well. And over time, every year or every 2 years, you ensure that they get screened as well, so that they don't have these problems.
Can I go
Alright.
back?
Say that again?
Omar,
was
can I
that?
go back to dry eye?
Dry
Yes.
eye, yeah.
Dry-
Go ahead.
yeah.
Go ahead. Let's
What
go.
I'd like to ask the panelists is, what does the patient present with in terms of what, after you've made a diagnosis of dry eye syndrome? If I come to you, what would I necessarily come to you with?
Right.
Symptom.
Good question. And it does, I'm gonna jump in here. It does vary. First, usually the complaint is my eyes are itchy, tearing, blurred vision. First, we manage the glasses part of their eye exam, but itching, tearing, and burning. Those are the big three. The others are mucus because the tears build up, but usually it itches, it's tearing, burning. They don't usually say the word dry because to them the eye is watering because the eye is reflexly crying. They're really watering on their cheeks. It's kind of a hypothetical, contradictory kind of condition. They're watering cheeks, their cheeks are watering, but the eye is physically dry. Not enough tears are being made. Not enough tears are being made to keep the eye lubricated.
Okay.
And sometimes, if I may add to that, it might actually be the very early signs of a systemic disease coming on.
True.
Often enough, vasculitis or autoimmune diseases that can begin with
Yes.
burning of the eyes or dry eyes. We have scleroderma, we have lupus, even rheumatoid arthritis. You'll be shocked. Sometimes that's how they begin. And of course, some visual problems like MS as well can begin like that. So if you begin to see that and it persists for 2 weeks or more, please talk to your doctor and of course get an eye exam done.
Right.
Righty. Excellent. I just got, go ahead. I'm sorry. I just got a shout out to our Facebook viewers. They're numerous, actually. I want to take a question off of Facebook. It says cataracts is common, a common illness among African Americans. And as an elderly individual, can we give some prophylactic measures to this problem? Okay.
Loaded. Good
Talking
question.
about cataract.
May I jump in?
Yeah, go ahead, Bob.
Yeah, that's a big question. The cataract is an aging process. Just like some of us get gray hair, lose our hair, the lens is going to change over time. Glasses, changes in glasses usually can help prevent the cataract from continuing to get worse, but at some point there's no turning back. Taking care of cataract surgery has become a routine-ish to the ophthalmologist. People don't stay in the hospitals except a few hours to get it done. The post-op care is relatively benign with drops for about a month, 3 to 4 weeks. But the cataract is an aging process that we really can't prevent except changing your glasses. And you and your doctor will know when those glasses don't change and it doesn't help, it's time to get the cataract removed. But you don't have to, you just won't see well. But it's a process that would improve your lifestyle.
Let me just ask a question, Bobby. What
Sure.
Exactly is a cataract? What is it?
I'm sorry.
Is it
I'm sorry.
calcium? Is it what is it?
As we described, the part of the eye called the lens.
Mm-hmm.
We're wearing glasses. These are lenses, artificial lenses. People wear contact lenses. The lens of the human eye gets, the protein in that eye becomes coagulated and it gets darker. So the lens in the eye is there are no vessels to the eye. There are no nerves to the lens. There are no vessels or nerves to the lens. So it's a organ that just sits there and just ages on its own. But that's what it is. It's the normal human lens that gets older.
Okay.
So Bobby, is there, I think
Yeah,
part of the question was whether or not there are things that might be done to prevent it. Are wearing lens that might protect from some of the ultraviolet rays from the sun help?
That doesn't hurt. It doesn't prevent the lens from aging. It does protect your retina, the macula. When we're wearing tinted glasses or photo gray glasses, we're really protecting the macula so the macula doesn't get beat up over time.
Okay.
But the lens itself, to a certain degree, can, but not as much as one would think. It doesn't hurt to wear them, tints or shades, but it doesn't really prevent the cataract from doing this aging thing. And anyone doesn't have to have the cataract removed. You can deal with not seeing so sharply. It's not a put down, but I know some ophthalmologists that tend to talk a little fast, so they might push you a little bit, but it's not a condition that has to be taken care of. But most people come running eventually.
Okay.
Now, I have a question. Dr. Cunningham, are there natural products that you can take that would enhance the vision and preserve the eye? Because we see a lot of things that are sold out there. And
right.
of course, some people talk about natural products in zinc and, and all those big stuff.
Right.
Are there things that can help preserve your eye and keep it?
Well, as we know, we're not a healthy society. Some of us aren't. Natural vegetables, plenty of protein, that good eating habits. A healthier person stays healthy over the body. There's nothing specific except some of the vitamin C does help the retina. It doesn't help the lens. Vitamin D is always good for other parts of the body, but not the lens. It's not the cataract itself. But good, healthy eating habits are often a way to, prevent the lens from over time from not having visual problems from the cataract.
Okay.
I'm sorry. I have a quick question for Dr.
Go ahead.
Sure.
Is there a relationship between cholesterol levels and the development of cataracts?
Cholesterol, no. Cholesterol used to be thought to be in the cornea. Even that has been ruled not really true. When you get arcus senilis, you get a white ring around your cornea, but not cholesterol to the lens. Now, cholesterol is a blood vessel issue, but good, healthy cholesterol balance, keeping your cholesterol lower is the key to living.
All righty.
But
All
not
right.
Thank you.
Let me go into another question. It's come over. I've had several questions come in about diabetes. I have diabetes and my vision gets blurred sometime. Why does this occur? Okay.
Very, very common condition. The back of the eye, called the retina, is the one that catches the problem. It's the blood vessels can leak fluid. The blood vessels can reabsorb that fluid. So it's the retina that often causes the problem with blurred vision, intermittent blurred vision. The lens itself swells too. If your sugar's out of control, the lens, i.e. the cataract, can progress. Actually get better vision if your lens gets swollen. You see better close up for a while, and then it goes back to normal. But no, the diabetes will decrease your vision over time if it's not controlled, and blurry vision is a beginning stage. You have to control your diabetic condition. We give drops, anti-inflammatory, that really kind of just tags along, but controlling the blood sugar is the key. You can get away with holding on to your vision for quite a while.
Mm-hmm. Okay.
If I may add to that,
Yes.
Back in the days when, as medical students and young doctors and everything else, we talk about the both sections of the eyes, the anterior and the posterior, and there's fluid within those sections of the eyes. And it's been said that, sugar actually get into those fluids because it's supposed to,
bathe,
go through and lubricate the eyes and everything else. Like sugar gets everywhere, including the brain, that the sugar goes into the eye, and sometimes it's not as metabolized or broken down the way it should be because we don't have insulin there. So sometimes those sugar turn into fructose-like components that eventually change the fluid within those segments of the eye. And that's where the first segment of changes in those visual perception begin. As a matter of fact, changes in the eye, what they call visual changes, can be the beginning and onset of diabetes coming up. So once you see that, please check your sugar, go see your doctor and see your eye doctor as well. I've always said this, everybody here should know what your diabetes status is. Everybody. Know what your A1C is. You have to know. So that if you're not diabetic, if you're pre-diabetic, or you become diabetic. Because in this country, 40% of people who are pre-diabetic would eventually become diabetic within, 4 to 5 years. So that's a huge number. Right now, we have
Yeah.
about 88 million people who are diabetic, pre-diabetic. So we need to keep that.
Yeah, and just to chime in on that, understand that 88 million people, how many of you said there, pre-diabetes is curable with exercise and weight loss. And that's a major deal as far as health is concerned because of the comorbidities that may come about because of diabetes itself. All righty. Any
Omar, question. This is Pat Anderson. Question for Dr. Cunningham.
Patrick, I was going to, this is the next thing I was going to do. Can you introduce yourself, please?
Okay, Dr. Anderson, Pat Anderson. I'm a gynecologic oncologist. I take care of women with cancer. I do some general and maintenance gynecology. I'm honored to be on the panel with this illustrious man. All these men are just wonderful mentors. So if you have young men who can watch this forum, please watch. You can get excellent mentoring from this group right here. Thanks for having me.
All right, go ahead, Patrick.
Dr. Cunningham, can you,
Yes.
not to advertise for specific products, but one, speak to the use of drops as for maintenance care of the eye? I see they advertise things like AccuVite. And also, can you talk about some of the changes that occur in the eye when women go through the menopause?
Wow. The AccuVite, let me address the AccuVite first. All of it has benefits. I'm not as versed on it as I should be, but the AccuVite is in the retina. We're not dealing with, that's not the lens itself. That's not the cataract. AccuVite is helping, I believe, the blood vessels in the retinal macular area. Your second point, I'm not really sure what changes that I could advise that women going through menopause. Usually when we hit 40, 45, 50, if you're nearsighted, you need glasses. That may be what they're referring to, not so much from a cause of menopause. It's we become presbyopic, we can't see up close, but that's usually a little earlier, I think, in the 40s. When is menopause? I forget, 50s plus?
Usually around early to mid 50s. Some of the questions I get asked is the onset of things like dry eyes. What is the cause? Will hormonal therapy help? And it's in the realm of how we practice, it's somewhat vague and really underexplored.
Right. We talked about that a little bit before you got on. Dry eyes is a common condition. It's almost the opposite of what most people feel. Most people say their eyes water itch, or they run water, or they're tearing. And here we as doctors calling it dry eyes. The tears are not being made as viscous as they should be. And the cornea, the cornea is not being bathed properly. So we add drops to bathe the cornea to give that lubricating feeling so they're not as irritated and dry as can be. That too comes along with, the dryness, the menopause, the women are having their issues, and the eye is very common there too. The other doctor mentioned rheumatoid or lupus. That's sometimes a red flag for those conditions. But the one that we see very, very common is just plain old age, and dryness, not so much from menopause, not so much from lupus, not so much from Sjogren's disease, but from just the lack of the tears, the lacrimal glands making enough tears to lubricate the eye. Doc, yep.
All right then. All right, thank you.
Okay.
Okay, I just wanted to make sure we had covered everything.
Oh yeah.
We're going to come back to the eye, but there are a lot of questions coming up with other topics, and let me get to a few of those. Here's one that states that, I think this one may be for me. Even though I have a minor case of obstructive sleep apnea, I have been on CPAP, the CPAP advice, complete with mask and hose. Should I be concerned about getting serious infections of the lung or elsewhere from using this device? All righty. You know, as far as the CPAP mask, and you can also say the nebulizer. A lot of people have a nebulizer at home as well as the CPAP mask, and you sleep with it all night. There are products out there that actually clean the mask as well as the tubing. But true, the tubing should be changed. I know the mask is expensive, and once the CPAP mask is fitted for you, it's your mask. So I would manually clean it frequently, but also there are products out there that will actually clean the mask and the tubing for you. All right. I have not had over the years any patients develop any significant lung infections secondary to their CPAP mask. But I would recommend cleaning it, you know, at least once a week. Okay. Let's see what we're going to here. Okay. All right, guys. All right.
Omar, I think there was a follow-up question as to whether or not sleep apnea was dangerous.
Oh, all right. Now, yeah, if that's a follow-up question, then we should address that. I didn't see that one. Let me tackle that right now, though. Sleep apnea definitely is a diagnosis that should be, if anyone thinks they have sleep apnea, they should be tested for that particular diagnosis. There are several major conditions that can come about secondary to obstructive sleep apnea, and most patients with obstructive sleep apnea are overweight or obese. And I always look at it this way. We gain weight not only outwardly, but we gain weight inwardly as well. So your airways get narrow, just like we got larger, and how we look, we're larger. Our airways got narrower because the things are being encroached on in the back of your throat. And what happens with obstructive sleep apnea is that you actually stop breathing, and the oxygen in your blood actually goes down to a very, very low, a dangerous level during that time that you stop breathing during that apnea. Secondary problems, secondary to that can come about because of obstructive sleep apnea, the number one that I think of is pulmonary hypertension. And basically what we're talking about there is that the blood pressure in your lung vessels increase. And when that occurs, that inhibits the ability of the blood easily going through those blood vessels that come through the lung to gather oxygen, to replenish the oxygen in your bloodstream. So that is something that is coordinated with the heart and the lungs, and the decreased amount of oxygen that is able to get into that bloodstream, and it causes a high blood pressure in the lung blood vessels. And because of that, you can become have significant heart disease, number one, but also lung disease as well. And so we should diagnose that. Dr. Daniels, is there anything that you deal with as far as obstructive sleep apnea, and as from a neurological or from a neurosurgical aspect?
No, not really, not in terms of obstructive sleep apnea. There's another type of sleep apnea called central sleep apnea, and there are certain conditions there's certain conditions in and around the brain that can cause pressure on a part of the brain called the brainstem that can lead to the areas in the brain that are responsible for letting us know to breathe malfunctioning. So oftentimes, just like Dr. Bay mentioned, when you're getting a study for sleep apnea, a sleep study, they're looking for both those things. They're looking for evidence of obstruction. Also, they're looking for evidence of central sleep apnea, meaning apnea without obstruction that might classically represent a decrease in the rate at which you're breathing. And under those circumstances, that it might require additional imaging studies. But in specifically talking about obstructive sleep apnea, no, there's not much in the realm of neurosurgeon, unless the rare case that you have a tumor that might be affecting what's called your lower cranial nerves that involve controlling your pharynx and your hypopharynx and your ability to swallow.
So Omar, I just want to do a couple of definitions. You know, when we're talking about apnea, we're talking about a cessation of breathing. And if you think about, let's just say a normal adult, they might have 15 breaths per minute. You might have heard something with those folks talking about George Floyd. But so if you talk about 15 breaths per minute, that means that each cycle of breathing is going to take about 4 seconds. And what happens is that you might take a breath in for about 1 second, a breath out for 2 seconds, and then there's a pause. And in that pause, before you take that next breath, the carbon dioxide level goes up a little bit, and that triggers you to breathe again. And so your brain is very sensitive to that carbon dioxide level going up, and that triggers you to breathe. And with sleep apnea, what happens is that there may be pauses in breathing that might be as long as 15 seconds or even longer. It could be as long as 20 seconds where you're not breathing. And when you're not breathing, that carbon dioxide is going up, as you said, because you're not expelling it. And then your oxygen level starts to go down. And what that then causes those blood vessels that you were talking about in the lungs to constrict, to tighten up. And that causes the heart to have to work harder, especially the right side of the heart that's pumping to the lungs. And that can cause that right heart to ultimately get larger and ultimately to fail. And so that CPAP stands for continuous positive airway pressure. So what that the machine is doing is generating a positive pressure that keeps the airway open, that allows you to breathe in and out. And as long as it keeps that airway open, then you won't have trouble breathing in and out, and none of those things will happen. Your brain will still continue to look at those pauses in terms of the slight increase in carbon dioxide that triggers you to breathe. But you know, if you have a partner who snores and may have apnea, you'll see that they may have pauses where they're not breathing at all. The chest isn't moving, and they won't actually take another breath until they change their position. And so that CPAP keeps that open and keeps you from preventing those pauses from occurring.
Excellent.
Omar.
Yes.
Omar.
Go ahead, Dr. Cole.
So,
Go ahead, Dr. Cole.
so you've diagnosed the patient with sleep apnea.
Yeah.
How do you counsel them in terms of what are some possible complications of this condition? What they can develop in addition to hypertension, strokes, heart attacks? What else?
Yeah, you know, all of the above, Dr. Court. Number one is that, and Dr. Sprock, you did an excellent job in describing. You know, the thing of it is that how we counsel, the number one thing that you can do for obstructive sleep apnea is weight loss. Weight loss. Well, there is, as Dr. Daniel said, central sleep apnea. Usually those patients are thin and not overweight. But patients that are overweight or obese, the number one treatment, true treatment for obstructive sleep apnea is weight loss. And I'm not talking about 100 pounds lost or 150 pounds lost. I'm talking some patients, they lose 20 pounds or even 30 pounds, and it completely goes away. The obstructive sleep apnea and all the apnea goes away.
Really quickly before we shift topics, there are mental health impacts to sleep apnea, like difficulties concentrating, anxiety, depression, memory problems. So that's definitely not to be discounted.
True. And I want to say that as far as the CPAP machine, that is a temporary therapy, meaning that does not solve that does not cure the problem. It helps the problem. It helps prevent those airways from closing off. What actually occurs is that we have a soft palate in the back of our airway, and that soft palate actually closes over that airway and causes obstruction. And basically, you will find if you're watching TV and fall asleep, and a family member may say, "Wow, you were snoring," and then you stopped, and then all of a sudden you started breathing again like that. That's classic for obstructive sleep apnea. And if you see a family member with that, they should go to their physician, their primary care physician, and be referred to a sleep specialist or a pulmonologist to be evaluated with a sleep study, overnight sleep study if possible. Okay. All right. Here's a question I've had. I have had a treatment with a laser surgery for glaucoma, and I take a prescribed drop daily. Is blindness an inevitability? Okay. Is Dr. Cunningham still with us? Thank you. I think he had they will get back to that question. All right. All righty. So here's another question here that had come through for Dr. Daniels. I have ringing in my ears for several years. What can I do about it? Is that something that you deal with at all? Or?
So not much, but the medical term that the patient's referring to is tinnitus. And it's something that 15 to 20% of adults experience at some point in time. A lot of times it can be caused by something as benign and as simple as maybe a whiplash or a ear infection or fluid in the ear, earwax. But if you are concerned that you've been having this tinnitus for years, then it means it's less likely as a result of something like that. Tinnitus can go hand in hand with hearing loss. And there are multiple different types of disease processes that can affect the hearing apparatus. The expert that you should seek evaluation and recommendations for is an ENT surgeon. And what they will do is everything from hearing tests to a physical examination of the ear to imaging studies to look at the hearing apparatus to give them an indication where there's something serious that needs to be treated. Sometimes people have tinnitus and they live with it just fine, and it doesn't affect the hearing loss. It's not associated with any other types of problems. But in the event that you've been having this tinnitus for a long period of time, especially if it's only in one ear, I would definitely see an ENT surgeon.
So one other thing, I know one of our colleagues, Dr. Kenny Gordon, sports medicine, he also does acupuncture, and my wife suffered from tinnitus, and she had some acupuncture treatments for it that helped relieve her tinnitus. So there's some other types of therapies, because very often, although the ear, nose, and throat specialists are particularly surgeons, rarely are there surgical treatments or cures for tinnitus.
Omar,
Yes, Dr. Court.
one of the problems that many of my patients complain of in reference to tinnitus, what I've been told in the past is that it occurs during the daytime, but you're not aware of it because of the background noise. And it affects the patients mainly at night. And one of the things that they try is to put the radio on, but not on a station at night. And the background noise from that humming sound from the radio tends to block the tinnitus. And that tends to work temporarily.
Something on in the background when you sleep.
Yeah, Dr. Daniels, you mentioned at the end, if it's on one side, is that a key for you? Is that something that you listen for in the history?
It is, because it might indicate a pathology on one side. So you have to be careful with the way that I see some of these things, because I'm a neurosurgeon and I treat brain tumors. Brain tumors are extremely rare, but I see them a lot in my practice. So when I think of tinnitus, what I'm looking for is a brain tumor in and around the ear, usually a schwannoma, right? So a vestibular schwannoma. So we do a workup that leads us in that direction. Mind you, those patients have already been seen by primary care doctors, ENT surgeons, a host of other doctors that have done a host of other tests before they get to that point. So for me, laterality, meaning being on one side versus another side, is important, because unless you are a specific type of patient with something like neurofibromatosis, right? If you have these issues on one side of the ear, I'm concerned that you might have a tumor on that one side. And so if you come and see me, when you talk to other doctors, like other real doctors, like internists, 99% of the stuff that, people are concerned about, I tend to order these more extreme studies quicker, because by the time patients get to me, then we're at the point where we're ruling out more dangerous things. So I don't want to scare people when they ask me questions about things like tinnitus, or there's another question about tremors, because before you would get to the point to where you would ask a neurosurgeon who's now looking for these very rare things that at times could also be very dangerous, there are so many other more benign explanations for the problem.
Dr. Daniels, would you consider an acoustic neuroma as a possibility also?
Absolutely. That's exactly what I'm talking about.
Can you tell me what an exclusive neuroma is?
So,
for the basic public, because we say these things and people don't understand what they truly are. Just give me a short description.
So if you think about it, your ear, so just think about it, right? You have two ears, and inside your ears is your brain, right? And the ear apparatus is in between. And the ear apparatus is controlled by nerves that come from your brain, a specific part of your brain called the brainstem, to your inner ear and your ear apparatus, right? Those are called the vestibular cochlear nerves. And one of those nerves particularly has the tendency to grow tumors or masses, cells that grow uncontrollably and then begin to push structures surrounding it on it. And it's a benign tumor in the sense that it's not the type of tumor that travels to other parts of the body, but because these things are confined within bone and there's not much space, it can grow and then begin to squeeze the nerve that it's associated with. And if it does that, you could begin getting symptoms. Those symptoms can be hearing loss. Those symptoms can be abnormal sounds. Those symptoms could involve balance or imbalance because the nerve for hearing is literally traveling with the nerve that's responsible for balance, because the ear apparatus controls both of those mechanisms. So when you see a neurosurgeon, you're usually seeing a neurosurgeon after you've seen other doctors, right? And then our responsibilities are now to rule out those things that neurosurgeons would treat, which are often tumors, right?
Right.
So, Omar, just one comment.
Okay, go ahead.
Well, similar to Dr. Daniels, from us, common things are common, but when we're in certain specialties, we see certain things more often than other specialties. With respect to ringing in the ears from a gynecologic cancer perspective, one, we know that certain GYN cancers, such as the high-grade uterine cancers and some cervical cancers, will go to the brain. And sometimes the first indication that something is in the brain is the complaint of ringing in the ears and persistent nausea. The other thing we need to often think about is, medications, certain therapeutic medications. For example, in what I do in cancer work, certain chemotherapy drugs will cause ototoxicity, or they're toxic to the ears. And one of those medications, which is common, is the platinum, cisplatin, is one of the common ones. So, the evaluation requires overall evaluation of the patients, their history, their current therapies, the medications that they're on, and often some symptoms that we often don't pay much attention to, like persistent nausea, which we often say, well, maybe it's what I eat, how I eat, when I eat.
Right.
Okay.
So, I mean, before, just like Dr. Williams, Daniels, and Dr. Anderson said, before they actually do go to them, they see the primary doctors, and often enough, first things first, and common things are usually common before the very rare ones. And when it comes to the ears, the common complaint is the dizziness, and the very common one is the benign positional vertigo, which, because the ear is responsible for not just the hearing, but as well as balance. And there's fluid within all those canals and the hair follicles that help, balance the whole thing. Sometimes they get displaced and people get, the dizziness and on top of that. But by the time you begin to have, one of other things like blurring of vision, hearing impairment, then it becomes a little more serious, and you have to take it, seriously. But then your primary doctor should sit with you, ask you those questions to, know exactly what the problem is. Is it just a benign issue, or just because there's a wax in your ear? You'll be shocked. Just wax alone. You look into there's wax filled up on one end, and once you take it out, it's all better. Or is this the beginning of a systemic disease? There's some other things they call Meniere's disease. These are autoimmune as well. And other autoimmune problems, that has to be ruled out. And of course, like Dr. Anderson said, medications. You'll be shocked that certain antibiotics that have been used, for instance, gentamicin, which are the aminoglycosides group, they don't use that much anymore because of those, side effects. Even aspirin toxicity, because everybody reacts differently to certain things. So you'll be shocked, but then you have to, eliminate those causative factors first, and then begin to, escalate, the signs and symptoms, and refer them to those who they really need to see.
Oh, excellent, excellent. There's a question that came in for Dr. Lee. I'm overweight and I had a knee replacement. The doctor did a bad job because I still have swelling and it still hurts. Should I get a second opinion? Not sure what to do next.
So that's a difficult situation. You hear me okay?
Yeah, I got you, doctor.
Okay, good. So statistically speaking, 1 in 5 individuals after knee replacement will not be satisfied. No matter what we do, you can make the knee and the x-ray look perfect. Starting with, being overweight, and I'm not sure if there's any other medical comorbidities such as diabetes, renal disease, cardiac disease that may contribute to some of the swelling. When an individual comes to the office for an evaluation after knee replacement with swelling, we typically do a workup and we say, okay, let's get an x-ray. Let's see what the knee replacement looks like. Is it infected? Do you have a temperature? Is there some other process going on, such as, maybe there's a rash, maybe, down in the lower extremity, there is venous stasis, or maybe the blood flow isn't so great. So there is almost like a dam effect where there's swelling in the leg. So, oftentimes you can have an operation that's technically executed well, but the result may not be what you want. And oftentimes there's expectations, what will my knee be like after surgery? And how does my, clinical circumstance, my health relate to that? So what I would say is I would get an x-ray. I would do an infection workup, make sure there's no underlying infection, maybe do a vascular study to make sure that the vessels are open, and then sort of go from there. The other thing we look at, is it loose? Is there the interface between the bone and the implant? What we look for is growth. We want the implant to grow into the bone, and sometimes it doesn't take. And that also can contribute to swelling, pain, and issues. So my recommendation would be, yes, get a second opinion if you're not comfortable with the doctor who did the surgery, and then undergo a formal workup so that, we can be objective about, what is actually going on.
Okay, thank you.
You're welcome.
Let's go back to this question, Dr. Cunningham.
Right here.
Yeah, I have been treated with a laser surgery for glaucoma, and I've taken prescribed drops daily. Is blindness an inevitability?
Okay. That is a very, very, very common question. The answer to that is no, it is not inevitable, thank God. The laser, there are debates now whether medication is better than laser better than medication, which one to start first. What we're finding, multiple studies, large center studies, that often a laser treatment, is multiple laser treatments, can prevent the person from having the burden of medication. If done right, and not every stage. Mild to moderate glaucoma can be treated with laser first versus drops and meds and redness and stinging. The cost of medication can be burdensome, as we know. Laser doesn't prevent glaucoma, it slows it down, just like medication, slows it down. Going blind is not inevitable. Follow-up treatment is important. Doctors will now often bring pressure down, the eye pressure down, that's what glaucoma is, by traditionally medication, eye drops, 1 or 2 or 3, or a laser treatment every 2 to 3 years. So no, it is not inevitable that we go blind with glaucoma, because we're able to get to doctors that can catch it and do something about it.
Okay.
I have a question, really. Dr. Cunningham.
Yes, right here.
Big issues, especially when it comes to our community. When I mean community, the Black community, those of African descent, wherever you are.
Right.
I've known some people like, oh, I have an eye problem, I have glaucoma. They'll ask you, are you African? Or are you from the Caribbean? Or, are you Black? One, is glaucoma more in those of African descent? And what are the common signs and symptoms on glaucoma, and what are the different, if there are different types of them?
Right. Good question. Good question. The glaucoma has been shown, open angle glaucoma, the common one that does not hurt. There's one that does hurt. They come in painful eye, the pressure sky high. That needs immediate treatment right away, laser or operation. But the one that's everyday bread and butter, I have glaucoma. Yes, it is. Multiple studies have shown that those of us from the continent are more prone to open angle glaucoma, primary open angle glaucoma. Not prone to it, but it happens a lot in our population. Might be because we're seeing more of our people here. It's worldwide, but yes, we have more of a tendency to have that problem. Your second point was, well, I'm sorry, Doc, what was your second question?
What are the signs and symptoms?
Signs and,
You know,
yeah, generally, yeah, that's a good one. Generally, if it's primary open angle glaucoma, there is usually no sign and symptom. Your vision is lousy, you can't see, you think it's glasses. Unfortunately, if we pick it up in a late stage, your side vision, your peripheral vision has really been compromised, really been decreased. But every day, moderate glaucoma, people don't really know it until they get one good eye exam, check their eye pressure, look at the optic nerve, maybe do a visual field OCT, and you usually get a good answer whether you have glaucoma or not. It takes about 2 visits, maybe 3, but 2 visits, yes or no. It's treatable. The meds are better now. Most meds are once a day. The lasers are effective, once a year, once every couple of years, if able. So things have gotten better for glaucoma, although glaucoma hasn't gone away anywhere. Eye pressure, usually we can't feel. And as someone said on the panel, make sure we know our A1C, which I don't know mine. Make sure we at least have our eye examined just to make sure the pressure is normal. Chances are it is, but you don't want to wait until we're too old to say, oh, I wish I had known.
So Dr. Cunningham, a question for you.
Yes, sir.
I've had a couple of patients, young patients, who have gone to the ophthalmologist for evaluation just routinely. And, they ask me, what does cupping means? And in some of my investigation, I've been told that in some African-American men, especially at an early age, cupping can be seen, and it may be idiopathic, meaning, there's no real pathology that you can assign to it. But is that a risk factor for developing glaucoma at a later age?
What you're describing, what we're talking about, is the optic nerve. The optic nerve, the center of the optic nerve should not be pale, should not be enlarged. It should be less than half the size of the whole optic nerve. Cupping means that the optic nerve, the center of the optic nerve, is a lot more pale, either from pressure, glaucoma, or a lot of myopes. Kenny, you said Dr. Sprott, you said you were myope. Some of you guys have nearsighted. Sometimes the optic nerve in myopes can look like that. Very, very common. Cupping is a sign that we do use clinically to make sure the cup is not enlarged. We can look at it in the exam room. We can do a quick OCT in the exam room to make sure that the cupping isn't changing and getting larger. Visual field picks up the cupping. We all have a little cup, but we don't want the cup any larger than half, 0.5. Myopes have a large cup, little red flag, but we just watch that.
Bobby.
Yes, sir.
Commented on the treatment for open angle. How about the treatment for acute closed angle glaucoma?
That's a good point. Luckily, we call it narrow angle or closed angle. Narrow angles are relatively rare. They usually are hurting. That pressure goes up, the fluid can't egress from the eye, the fluid can't go out of the eye. And there's only one way to get it down, is make a iridotomy. First, we put them on drops to get them out of pain, and we make a small iridotomy, a hole in the iris, and it resolves it. So narrow angle, chronic narrow angle glaucoma happens. It's rare. We see it once, twice a year at most, but it's out here. When the eye hurts, people come in and find out what's hurting, and we can pick it up, whether it's an infection or whether it's glaucoma or whether it's a foreign body. But chronic narrow angle or closed angle glaucoma, fortunately, is not that common. And as soon as it's picked up, as soon as you send them across the street, we know how to help resolve that issue. And it usually goes bilaterally. So if we know one eye's in pain, the other eye's coming.
Okay, excellent.
Sorry, not to count this. We live in an age where we've all gone, virtual with regards to COVID.
Right.
Now, what would be the, today, tomorrow, or the near future, what we expect now that, even from the elderly or the most older people down to our kids, have all gone virtual and we're all looking at screens. What would be your, advice with regards to this, Dr. Cunningham?
I'm sorry, regards to glaucoma? No, the narrow angle glaucoma?
No, no.
Or in general?
Going virtual and staring on the screen most of the time, anyways. What damages
screen wise
you expect with the eyes?
Yeah. Health. Good question. Good question. Using our eyes does not make them tired or worse. Either we need, the eye either needs glasses or not. It's like using our nose. We smell, even though we smell the delicious ham cooking or the beans cooking or some stinky socks, it doesn't make the nose worse or better. So using our eyes, good lighting, of course, good rest, those things can keep the eyes going, but using your eyes will not wear the eyes out.
All righty. All right. Well, it's halftime and boy, time is flying today. So, and the questions are coming in and the questions are great. I still want to give a shout out to our Facebook viewers. Boy, your questions are good, and give us a thumbs up, give us the heart, click it, let us know you're there. But I see all of the names coming up on Facebook. Let me do this as far as halftime in saying that and I'm going to start with this. Do not change any aspect of your medical care until you consult your physician, no matter what we say today, because only your physician can treat you best for your medical problems. That's so, so important. So do not change. I want to say it again. Do not change any aspect of your medical care. One thing I want to do a shout out. This is actually, I think this is the first real shout out that we've done on this show. That the New Jersey Black Doctors, or New Jersey Medical Association, along with the New Jersey Elective Black Caucus and clergy, are what they're doing is they're doing a community vaccination day. All right. And this is Sunday, April 18th at 12 o'clock to 4 o'clock, 12 noon to 4 p.m. And it's going to be, if you're in the area of Orange, New Jersey, it is 485 Park Avenue, Orange, New Jersey. And that is Sunday, April 18th from 12 o'clock to 4 p.m. They're doing a community vaccination day. Now, how do we connect with this? You have to pre-register, and because they only have a certain amount of shots that they can give out. So you go to their website, which is njmedicalassociation.org. Let me say it again, njmedicalassociation.org. And you pre-register. What you do is hit contact them, and send them an email and give them your name and your phone number. They will call you back and give you a time and when to come in and where to be to get your vaccine, COVID vaccine. So this is a community vaccination day that the physicians, the Black Medical Society of New Jersey with the Legislative Black Caucus is putting together so that we can help give our community, those people in the Black community that want COVID vaccine. You can pre-register at njmedicalassociation.org. Just email them through that website, give them your name and your phone number. I just want to let you know, and I give a shout out to all of the legislators and as well as all of the physicians and nurses that will be there to give out vaccines that day. Okay. What I'd like to do is I'd like to thank OBHealthy for allowing us to use their platform to come out and bring this webinar to you. And yeah, we're going to move forward here. Okay. There was a question that came in, and this is for Dr. Cunningham. It says 1 year ago. Oh, excuse me. Let me step back. Let me reintroduce everybody because there were probably people that came in and missed the introduction. Okay, so I will introduce people depending on my screen. I'm going to start with Dr. Salam. Dr. Salam, can you introduce yourself? I'm sorry about that. I got ahead of myself. You're on mute, Dr. Salam.
Good afternoon, everyone. I'm Dr. Kareem Salam, and I'm a board-certified adult and child and adolescent psychiatrist. Delighted to be here.
All righty. Dr. Aluya, you're next. Is Dr. Aluya there? Okay, Dr. Court, we'll come back to Dr. Aluya. Go ahead.
Dr. James Court, Howard University, class of 1980. internal medicine, East Orange, New Jersey.
All righty. All right, Dr. Aluya, you're next.
Oh, yes, sorry. Nelson Aluya.
Dr.
Now-
Aluya, you have something else going on there? You have a feedback. Can you turn that down?
Yeah, it's re-vibrating, sorry. Nelson Aluya, medical advocate, what do I say? Medicine pediatrics trained. Delighted to be here amongst these great minds. Thank you.
All righty. Dr. Daniels, please.
Hey, Dr. Lawrence Daniels, I'm adult and pediatric neurosurgeon. Pleasure to be here.
Okay, thank you. Dr. Anderson.
Yes, Patrick Anderson. I'm a board certified gynecologic oncologist, practicing in the Newark and Essex County area with many of these doctors on the panel. I'm happy to be here.
All right. Thank you. Thank you. Dr. Cunningham.
Dr. Bob Cunningham, ophthalmology here in Essex County. With our panelists are enjoying the afternoon. Glad to be here.
All right. Thank you. Dr. Clark.
Good afternoon, Dr. Kevin Clark, surgical oncologist at Newark Bethesda.
Okay. Dr. Lee, please.
James Lee Jr., board certified orthopedic surgeon. I want to give a shout out to Bloomfield College. I'm a prospective board member. It is a historically Black institution, as well as supports Latinx students. It has the first African-American president in its 150-year history, Dr. Marquita Evans. Support our New Jersey's HBCU.
Excellent. Dr. Sprott.
Kendall Sprott, general pediatrics and pediatric critical care.
All righty. And I'm Dr. Omar Bey, pulmonary critical care with a subspecialty in nutrition. And I'm happy to be here with all the brothers. All right. Dr. Cunningham, this question came through. 1 year ago, I was diagnosed with central serous retinopathy. My doctor did not want to do cold laser therapy and just advised me to take lutein, is it lutein or lutein supplements instead of which I have been, which I have been doing. Since then, all has been well. Should I be worried about this situation coming back or getting worse in time?
That's a very good question. I'm happy for the result. The condition you mentioned is central serous choroidopathy.
Mm-hmm.
Basically, it's chronic fluid in the macular area. Usually the cause is unknown. It's not diabetic, it's not a vein occlusion. It's often one of the weaker layers in the retina that erodes, and it just won't improve without some type of therapy. I'm not aware that there's a laser therapy for that. A cold laser, I'm not really aware what that was, but lutein, there are some medications that do help slow down the leakage from what I understand. One is lutein, another one is, I can't think of the name of it now. Fortunately, we have plenty of retina doctors, retinal specialists in the area that take care of this condition. A generalist like myself, once we diagnose it, once we make sure it's not a hypertensive issue or diabetic issue, we refer them right to the retina specialist. They manage from there.
Okay, I think we're losing our connection already. Okay, but that's all right. That's all right. I think we got most of the question answered. And is there anyone else that want to chime in on this? If not, when we get Dr. Cunningham back, we will finish up.
Usually, if I may say something, there are 10 layers that form the retina, and each and every one of those layers have blood supplies in all of them. And you can bleed into any of those spaces, and that's why sometimes you hear what they call retinal detachment, because there's bleeding within one of those layers. And two things that are very common that can cause both, which is very common in the Black community, is one, hypertension and diabetes, where you have, retinopathy, because of very uncontrolled, long-standing, diabetes or hypertension can cause the vessels to get bigger and wider, and then they begin to leak. As they leak in between those layers. So, and those are things that can happen. So, and that's why we can't overemphasize the fact that if you are diabetic, you have to control it. If you have hypertension, you have to control it. Like I always say, if you have both, that's a double whammy, and you have to control that essentially. But for you to effectively do that, you have to really sit down with your doctor, who you have a communication with. Um, Establish a relationship with your doctor so that he knows you, you know him, and you come up with a plan that suits you as an individual. Because the way you manage your diabetes is very different from the way I would manage my diabetes based on a whole lot of factors, genetics, environmental, the food we eat, our cultural backgrounds and all that. So that's why it's so important we begin to do that.
Excellent, excellent. All righty. There's another question, and this is an important question, I feel. I'm 6 weeks pregnant, and I noticed that the mucus I sniff out from my nose has changed the color, and the color is green at this time. Please, what does this mean, and how bad can it get for my baby? Thank you. All righty. I know we have some internal medicine, and we have Dr. Patrick Anderson. Of course, I'm going to direct it to you.
I'm not sure the relationship between the mucus from the sinuses and the pregnancy. Physiologically, there may be some hormonally related consequences, and I'm basing this on what I know that happens to cervical mucus. With high levels of estrogen, it becomes thinner and more and less viscous and flow more rapidly. With respect to a color change that's green, one would have to wonder if there's some infectious process going on in the sinuses. So this person probably should be evaluated to see if there's some sort of a sinusitis that's really unrelated to the pregnancy. This, I can think, is an unusual development that would be related to the pregnancy.
Okay, yeah. The likelihood that bacteria from the sinuses would get down to the baby is unlikely.
And that is unlikely, yes.
Okay, all righty. There is a question that came through. I had cataract surgery done in both eyes. How long does the correction last? Also, my light vision, maybe it should be night vision, or my light vision is not so great when I'm driving. Seeing spots, lights are shining in my eyes. Does those night vision glasses work? Okay, and there's something about TV as well, that they advertise on TV. Can you help me out with that, Bobby? You're on mute, Bob.
Better?
Yeah,
Okay.
thank you.
Very common, one eye, both eyes, very common for people to have both cataracts performed. Usually their vision is good. There is a caveat, however. Sometimes and oftentimes, months, maybe years later, a year later, the cataract that's been removed has had an implant put in. We take out the old lens and put an artificial lens in, very well designed. Sometimes that lens will cause a little, become fibrotic and scar and knock down night driving vision. We call it glare. We call it a secondary capsule fibrosis. It's usually removed right in the office with a laser. Vision comes right back. We enhance the glasses. We kind of have to redo the glasses or not. You just get a measurement. Sometimes it goes right back to the glasses you've had after surgery, but it's not uncommon for people after cataract surgery, months or years later, to have a secondary issue with the night driving and glare. The glasses promoted on television, I'm not sure that they're all that much cranked up to be. As long as the prescription is correct, anything to hold down glare in the night driving vision can help. I'm not really sure that they're the best ones since they're on television. But again, it's not uncommon for after cataract surgery, years later, for people to have a little secondary issue, which is often cleared right up either through a change in glasses or a laser procedure in the office.
Okay, thank you.
Okay.
I have a couple COVID questions coming through, and I'm going to summarize. There is one question that came through that stated that a young gentleman had gotten COVID, and he was tested positive for COVID, and he had symptoms actually. And that post-COVID, at this particular point, and it's been a while since he was tested for the COVID, and most of the symptoms went away, but one symptom stayed. He says that he's getting chest tightness when he sits up in bed or sits up in a chair. He states that it is getting better over time. He wants to know, is it secondary to the COVID, and will it go away completely? Can we help? And I think this is something that, we've been reading about COVID and post-COVID morbidity and more. One of the things that's called is long haulers, I think. Can someone give us some more information or for more clarity as far as this is concerned and whether we think this is associated with COVID? Kendall, can you help us out with this one?
Yeah, the answer is maybe, but maybe not. I think that most of the individuals that have COVID infection, it is primarily a respiratory infection. It hits the nose and then travels down, and they may have lung symptoms and may have inflammation of the lungs that might lead to some kind of tightness. It's hard to know. Most of the individuals that have relatively mild disease recover, and they're never really tested. They wouldn't go necessarily to a doctor to do pulmonary function tests to see whether or not there might be any objective evidence that there's some problems that are going on. You as a pulmonologist will know that very often you don't know if someone had pre-existing conditions, so you don't know whether or not they were the same before they had an infection or that there was a change afterwards. I think if there's a question about whether or not there are issues related to the function of the lung, it might make sense for them to see a pulmonary specialist and have some simple tests done. But when you look at the various complications related to COVID, we really don't know all that's there, but we know that there are a large number of individuals who are having both cardiac as well as pulmonary symptoms after they've recovered. I guess the only way to know for sure if there are issues related to the lung is to have the pulmonary function testing done. But then you don't know whether or not that was because of COVID or because they had some underlying conditions. A lot of the people that have underlying conditions of lungs like asthma or things like that, very often they have symptoms that get worse over time or then come and go. So I would say that if they have a question about it, to ask their primary care doctor to see about having a specialist do some pulmonary function tests.
Mm-hmm. Excellent. Yes, go ahead, Dr. Cord.
I agree entirely with Dr. Sprott. We need to know what happened before, whether this patient had heart disease before, and certainly after. So it all depends, was he or she going to see a doctor before, and was he or she diagnosed with heart condition before? If we don't have any data in terms of what happened before, how could we tell what happened after? However, COVID is known to affect just about every organ, so it's very possible that this is what the patient had. It's a sequelae of COVID infection.
Right. Dr. Nelson Aluya.
Yeah, in my experience, I've noticed, especially for those who have had very severe COVID, that end up in the hospital either being intubated or just being on long-term use of CPAP or oxygen. When they come back, they tend to have a longer affectation of their lungs. They tend to have problems, coughing and stuff like that. I have two people right now who are still going through it. But again, COVID affects every organ in the body. We begin to read reports of, people who have had strokes, increasing reports here in the US. They've had multiple back in Europe with the issue of dementia and neuropsychiatric issues right now. There's an article that came up, I think, New York Times. A young and I've had reports and seen a few articles as well. Individuals who had mild cases of COVID, and then subsequently a month, 2 months afterwards, started having, depression and then psychiatric issues, even ending to the point where they get admitted into the psychiatric hospital. So we begin to see a whole lot of this as well. So I'm sure Dr. Karim will talk about that with regards to, I think there's about 2.5% increase risk of depression, severe depression in young individuals, especially those of African American descent. So we need to pay attention to things like this.
Well, absolutely. I couldn't agree more with Dr. Aluya. And I'm very impressed you quoted the Science Times article from the Tuesday edition of the New York Times from a few weeks ago, where it showed a few cases of folks who were affected by COVID, and they had pretty severe cases of post-COVID psychosis that resulted in acute inpatient psychiatric hospitalization. So as someone mentioned earlier, I think maybe it was Dr. Aluya, no organ symptom is exempt from the scourge of COVID. You have folks who are suffering from depression and anxiety, in addition to the kind of somatic health problems as a result of COVID. Moreover, the public health recommendations to keep folks safe and to mitigate the spread of COVID has psychological impacts, whether it be the social isolation, the financial stress and secondary depression and anxiety because folks have been furloughed and laid off, and the kids, they're socially isolated because they're no longer in school. While I have the mic, I really want to encourage the parents of school-age children who are managing their educational process at home, please do not take their devices away from them. Their cell phones, their tablets. In the setting of COVID, this is a lifeline for these youngsters. Remember, they're not in school. The vast majority are not in school. They're not seeing their friends. They're being deprived of important milestones, athletic competitions, musical performances, just venues where they're being validated. And all of this has been stripped away from them. And so these devices help them remain connected to their peers. So sadly enough, I've had a number of kids admitted to my unit who have been suicidal because their parents have punished them by taking their devices away from them. And now they're cut off from communication with their friends. So I would advise against that. And we should also be empathic and give these youngsters grace, because many of us take these milestones for granted. We've gone to proms, we've had graduations. So imagine how we would feel if we were deprived of these important developmental markers.
Okay, excellent, excellent. All righty. I think we've covered that. Dr. Kevin Clark, there was something that came through. It says that, does it, let's see, as far as colorectal cancer, does it occur more in African Americans, and is it more severe / deadly? How can we improve on this?
So I'm not sure it necessarily occurs more often, although the incidence certainly is increasing, especially in younger African Americans. So if you look at the numbers, most colorectal cancers are diagnosed after age 60. So the 60 to 70 age group is the highest incidence. But in the group of younger patients who do get it, and when we say younger, we're talking about below 40. It seems like the incidence in African Americans is increasing. And that was one of the reasons last year, some of the societies actually recommended switching, or at least moving back the age to start screening from 50 to 45. As far as the virulence, it depends on the stage. So as with any cancers, your opportunity for cure depends on your ability to diagnose it early. So the earlier we diagnose cancer, our ability to cure it increases. With colon cancer, that means regular screening, appropriate screening, which does two things. It actually prevents the development of cancer by removing polyps. And if there's a cancer that is there, hopefully with regular screening, you're picking it up at an earlier stage. In general, I think there are a number of reasons why the mortality is higher in African Americans. And again, this applies not just to colorectal, but to breast and other cancers. A lot of it has to do with the stage of diagnosis. So certainly our cancers are picked up at stage 3, 4 more often than stage 1, 2 compared to other demographics. But it also has to do with access and also patients taking advantage, even when they have access to resources. So it's a complicated situation. But this is actually, we're out of colorectal screening month. Actually, March was colorectal screening month. Now April, I don't even know what April is now.
Okay, all righty, excellent.
Omar, can I just
Go ahead.
make one comment?
Yeah, man.
A part of it, Kevin talks about screening, but a part of it is recognition as to, whether individuals have intrinsic risk factors that are genetically based. So it's important that when any individual sees their primary care doctor, a critical family history information is important because there's certain cancer syndrome of which colorectal cancer is a part of it. Kevin and I often deal with patients with Lynch syndrome or hereditary non-polyposis colon cancer syndrome. And the implication of this is far-reaching. It could include both ovarian, endometrial cancer, prostate cancer in men, and of course, colorectal cancer in both genders. So family history is important. That needs to be presented at time of evaluation with your primary care physician. The importance there is that now we have, genetic testing that's widely available that can establish put you in a risk category that help us decide when and how early to begin screening.
All righty. Definitely. All right. There was thanks, Dr. Anderson, 110%. There was another question that came in, Dr. Daniels. This question is about a cyst or a tumor around the optic chiasm and decreasing vision. Can you give us some indication? It doesn't give me too much clarity on that, but obviously something's pressing on the optic chiasm and their vision is they're losing their vision.
That's me, Omar?
Yeah, that's Dr. Daniels, I thought. Well, either of you, if you want to start off.
Dr. Daniels, go right ahead.
I'm sorry. Okay. I was on mute.
No. You want me to repeat it?
No, I got it. I was answering the question from someone on
Okay.
purpose. All right. So I'm assuming this is an adult patient, and if it's an adult patient, the most likely tumor that it is a supracellular tumor. The most likely tumor in that region is a pituitary adenoma. And so a pituitary adenoma is a tumor that is associated with the pituitary gland, which is essentially the master gland. It is a part of the brain that sends signals to other parts of the body and regulates their hormones. And sometimes we can get a growth in this tumor. And because this space is really, really small, and the tumor essentially is right behind the nose in the brain, the eyes, the nerves that come from the eyes come together in the middle of the brain right behind the nose in what's called the optic chiasm, where these nerves merge and then eventually go back to the brain, is located in that area. So sometimes one of the signs of this tumor getting larger, these cells growing abnormally, increasing in size, they begin to then compress surrounding structures. And one of those structures is the optic nerve. So, sometimes pituitary adenomas are tumors that are benign in nature. They won't travel to other parts of the body. And the only real issue with them is that they can grow and begin compressing on the optic chiasm and lead to blindness. And that's an indication for surgical intervention. But some of these types of tumors don't need surgery. And it depends on a certain type of hormone, whether they secrete it or not. And you need to see an endocrinologist to sort that out, because some of them can be shrunken and reduced with medication. But if it's not that type of tumor, and if it's the type of tumor that will continue to grow, then it requires surgery. The most common surgery that's done to treat this is something called an endonasal transsphenoidal approach, where an ENT surgeon and a neurosurgeon stick a probe up your nose and get access to the back of your nose and that area in the brain. And then we take off the bone in that area. We open up the dura, which covers the brain. And then what we traditionally do, depending on the size of the tumor, is we gently allow the brain to push that tumor out. We have these special small tools that are like these rings with sharp edges. And we go in and we gently scrape the tumor because we don't want to affect the normal pituitary gland. And the whatever is usually loose is usually the adenoma, and it usually comes out nicely. And then you close it up. You stay in the hospital for a few days to make sure you don't get fluid leaking from your nose. And people usually tolerate the surgery very well. Dozens of people have the surgery every day. So if you are having visual symptoms, that's an indication to do the surgery, because if the tumor continues to grow, either do the surgery or get the tumor treated, depending on the nature of the tumor. Because if the tumor continues to grow, it can continue to injure your optic nerves. And one thing that we know in neuroscience in general is once you have a deficit, and your neurosurgeon will tell you this, we're doing the surgery not to reverse your deficit. There's a chance of that, but there's no guarantee. But we're doing the surgery to prevent your deficit from getting worse. So at this point, time is of the essence, and you really need to speak to a neurosurgeon and a neurosurgeon, an ENT surgeon, and a endocrinologist.
Mm-hmm. Excellent. Thank you very much. That was very well covered. There are questions about the cuffing. I think we may have answered these. Dr. Cunningham, you still here?
I think,
yeah. So there was one about hypertension and cuffing, and then there was another one about the pressure in the eye. So is as far as hypertension and cuffing, is there an association, or is there?
No. Let me jump in. Two different concepts.
Okay.
Hypertension, and we tell people glaucoma is conceptually hypertension of the eye. The pressure is high, not hypertension, but the pressure in the eye is high, and sometimes it's not. And that's what's causing the damage. There's really no controlling our eye pressure. Good healthy eating, good lifestyles one way. Genes, your lucky genes are another way, but there's no way to control the eye pressure. Keeping the pressure down elevated eye pressure causes cupping. More pressure on the optic nerve blows out the center part of the optic nerve. So hypertension and glaucoma cupping are two different things, but conceptually there's pressure in the eye. Our goal is to get the pressure down. Medications are good, but burdensome. Laser is effective over time. So we do get the pressure down in those ways, but the hypertension, high blood pressure, does not cause glaucoma in itself.
Okay, all right, excellent. There was a question that came in for, I think Dr. Anderson may be able to help us out with this one. I have endometrial cancer, stage 4. Can you explain what that means?
Yes, Omar. So endometrial cancer is one of the cancers that develop inside the womb, the uterus. Typically, there are 4 stages. Each stage, however, is subdivided depending on certain prognostic features. And what that means is there are certain things that the pathologist will look at within the tumor and describe them. And some of those features are how the tumor look. We call that the grade. A grade 1 tumor is one that almost looks like a normal piece of the endometrium or the tissue lining the uterus. A grade 3 tumor is just sheets of cancer cells that's unrecognizable, where if you don't tell me it's from the uterus, I couldn't tell you where it came from. And then there is how deep it invades into the muscle of the uterus, whether it's less than a half or more than a half, or it goes to the outside of the uterus. Other features include whether there's pieces of tumor within the tiny lymph vessels or in the tiny blood vessels. So when these cancers are confined to the uterus, that's a stage 1. The stage increases, however, when these tumors leave the uterus or exits the uterus. It becomes a stage 2 when it goes from the uterus into the mouth of the womb, the organ we call the cervix, or it drops down into the vagina. It becomes a stage 3 when it's in other parts of the pelvis. So if it exits the uterus, but it is attached to, say, the colon or the side wall of the pelvis, then it's a stage 3. It becomes a stage 4 when it gets into the upper part of the abdomen, when it gets onto the liver, when it gets onto the diaphragm, the muscle that separates the chest from the abdomen, or it's in the lung tissue, or in the space between the lung and the chest wall, or any other place outside of the abdominal cavity proper. Hard to say specifically how I would counsel this patient without knowing specifically where the tumor is, but this is an advanced stage. There clearly is treatment, multiple treatments. The approach depends on how much disease, we call it the tumor burden, the location, and the symptom the patient is having. And as important, whether there are underlying medical problems, how risky it becomes to the individual by putting them through certain procedures and treatment. Obviously, the prognosis and the ability to cure this, like any other cancer, depends on staging. And obviously, a stage 4 is harder to cure and treat than a stage 1. The hallmark approach to treating uterine cancer is surgery, but sometimes, we have to do what we call neoadjuvant therapy, which could be neoadjuvant chemotherapy or radiotherapy, meaning treatment before the recommended primary treatment. And that allows us to sometimes shrink the disease. It gives you a sense as to the responsiveness of this tumor to treatment. And then if the patient responds, then we'll feel better exposing them to the risk of surgery. Oftentimes this is radical surgery. Kevin and I often collaborate on some of these operations because some of the things that needs to be done, is extensive, far-reaching, requires reconstruction, and sometimes, patients' lifestyle has to change because of the outcome or the anticipated outcome. So that's what stage 4 means. Uterine cancer is what we call a surgical staging. Usually you have to have surgery and have the lymph node biopsy, have biopsy of any tumor or area of suspected involvement in order to explain how widespread the disease is.
Okay. What I'd like to know is she's talking about stage 4, which is advanced. Patrick, how do patients present, and how can we catch it early?
Cervical cancer, unfortunately, pardon me, not cervical, uterine cancer, unfortunately, there is no specific screening for uterine cancer. Commonly, uterine cancer occurs in patients older than 50, usually patients who are post-menopausal. However, there are certain groups of younger patients who are at risk for uterine cancer. And let's look at the younger patients first. Those patients in high-risk areas includes patients with certain genetic risk factors. So for example, I had mentioned hereditary non-polyposis colon cancer disease before. For those patients, the mean incidence of uterine cancer is about age 49. There are certain breast, ovarian, endometrial cancer syndromes, which obviously put patients at a lower development of disease at a younger age. And then there are certain other gynecologic issues, such as polycystic ovarian syndrome, of which the menstrual period is irregular. And one of the intrinsic protection that women have is the cyclic nature of their menstrual cycle. Estrogen is a great hormone to have. It's a great drug to take most times, but unopposed estrogen use can lead to uterine cancer, which is essentially building up of tissue inside the uterus, and then those tissue becomes cancerous. So polycystic ovarian syndrome is a condition where there are multiple cysts in the ovary, and those patients are exposed to long, consistent exposure to estrogen, no counteraction from the progesterone, which the ovary makes as well. And those patients at a young age can develop uterine cancer. And then there's the issue of obesity. Obesity is significant in the sense that there's a different type of estrogen from the one made in the ovary that's result from the conversion of a precursor male hormone from the adrenal glands, androstenedione, to estrone in the fatty tissue. And that also can cause unopposed exposure of the endometrium to the hormones, which ultimately put them at risk for uterine cancer. Now, in older patients, bleeding, postmenopausal bleeding, is probably the earliest sign. Obviously, we keep patients who have personal history of other cancers in mind or family history of similar cancers in mind. And we look at them in a different way. Typically, we don't get ultrasounds of the uterus in the general population, but however, in patients with certain risk group, you may want to do that. Patients who have some of these family history of cancers, because a thickened lining on the ultrasound, even in patients who are asymptomatic, patients who are not having pain or bleeding, may warrant evaluation of the endometrial cavity, right? The majority of time, it's not cancer. It could be other benign things like fibroids or polyps. But the most consequential condition is cancer, and you want to rule that out. It's very important that if you have not had a period for more than 6 months and you bleed again, you bring that to your medical provider and have them refer you for appropriate evaluation. This has nothing to do with your virulence, okay? If you bleed after you've been through the menopause, you need evaluation. Now, the most common cause of bleeding in the postmenopausal age group is not cancer. It's a condition we call atrophy. Because of the lack of estrogen, the endometrium, or the lining of the womb, becomes quiescent, so it becomes thin. So you can have an immunologic reaction from the underlying tissue, and you can get this bloody serous discharge. However, because cancer is the most serious consequence, you want to rule out that first before you can feel comfortable that this is what's going on. Other things like inflammation and infection in the uterine cavity can cause bleeding. Now, 80% of women who bleed, even when they bleed for up to a year, the disease is still confined to the uterus. So typically, excuse me, when you see extensive disease like this, symptoms have been going on for a very long time, or there is one of these other subtype of uterine cancer, which is a very aggressive, like the carcinosarcomas or the papillary serous type or the squamous cell type. So these are typically some of the more aggressive cell types. And those are known to spread very, they spread very early and are far reaching very quickly. So symptom is important. Knowing your risk factor through a family association is important. And if anything that's not usual, don't rationalize it. Just seek evaluation.
Mm-hmm. Excellent. Excellent.
Questions, Patrick.
All right.
Yes.
Patrick.
Yes, doctor.
In reference to patients that we see with postmenopausal bleeding, is the type of bleeding have any indication as to whether or not this is from ovarian uterine cancer or not? I was told once that if it clots, it's more than likely related to it's not cancerous. Is it true? Is there some truth to that, the type of bleeding that occurs?
There's absolutely no truth to that.
Okay.
Any bleeding can have serious consequences. So oftentimes what happens is, it's the rationalization, which is really unfounded. So any bleeding is important. If it has an odor, then that's also ominous. Because there is significant necrosis of, meaning dying tissue, which is significant. It can speak to the aggressive nature of the cancer, or there's an associated infection.
Excellent. Excellent.
Yeah, I think that's important. They don't qualify what the characteristics so much are. It's the same thing with rectal bleeding too. it's colon cancer can present, or rectal cancer can present the same way as hemorrhoids, and hemorrhoids have the same presentation sometimes. So, but it still needs to be evaluated. So you don't want to say because it's a particular way that it's unlikely to be rectal cancer. So it's important not to, as Patrick said, rationalize away something that's a abnormal presenting symptom.
Okay, excellent. I have questions coming in about COVID. It says, are there any pros and cons against, are there any pros and cons amongst the three available vaccines? Okay. Can someone start this off? I know the vaccines and taking the vaccines has been a big issue, and especially in the African-American community. But can we talk about this just a little bit as far as that's concerned, pros and cons, and why different people have different thoughts as far as the vaccine is concerned? Dr. Salam, you want to start?
Sure. Before we get into that, I'm wondering if by a show of hands, we could show our audience how many of us have been vaccinated.
Sure. Okay, so that's right there.
And by the way, I just responded to that question in writing.
Okay, well, let the rest of us know what's happening when you responded. Can you talk about it a little bit?
Sure. So, and again, we're talking about the pros and cons of the vaccine. So the pros are pretty obvious. So the vaccines mitigate or lower your risk of serious illness and death should you become infected with COVID, which is a very contagious virus that's new to human beings. So coronaviruses have been around for a while, but SARS-CoV-2 is the novel or new coronavirus. So the vaccine already, it decreases your risk of serious illness and death. And there's been so much serious illness and death secondary to COVID in the Black community. So that's the major pro. And really the one that's probably worth highlighting first. The major con, I don't think is that major at all. So some of the common side effects of the vaccine are injection site soreness. I actually experienced that after both of my injections, and I got the Mrna vaccine. And my experience was pretty benign. Most people that were vaccinated at my job had some difficulty, whether it be headache, fever, fatigue, sweating, and it was usually very short-lived. And that could easily be explained because the concept of vaccination is really preparing the immune system to fight an enemy. And the vaccine is basically, it includes genetic instructions for a piece of the enemy, which is the spike protein. So that when the body sees that spike protein, if you get the COVID infection, it's ready to fight. And part of that is, part of the inflammatory response, which is responsible for the fever. So that is temporary discomfort, and that's the price you may pay for decreasing your risk of serious illness or death. And the benefits of vaccination far outweigh the risk of side effects. So the benefits of vaccination against a potentially deadly illness far outweigh the risk of discomfort, temporary discomfort from a vaccination.
Dr. Salam, okay.
Go ahead, Dr. Corey.
I echo what you said, and I wish, we could just broadcast this to the whole world. One of the other things that I mentioned that I've thought about recently is you refuse a vaccine, you can get the virus and then infect your entire family. This is serious business. You could infect your entire family. You don't want it, but you pose a risk to your family members.
Yeah.
Yeah. Anyone else want to chime in on this? This is a topic that we should all, if you have something to say or if you have some belief, let's hear it. Dr. Daniels, you were getting ready to say something?
Yeah, the way that I read that question was someone was asking about what are the pros and cons of each of the different types of vaccines.
Right.
Dr. Salam discussed the mRNA vaccine, and I can't tell you the number of friends I've had discussions with who get their information on social media and other, not informed places who don't understand. And, that's reasonable because it is advanced technology. But what people need to know is that the mRNA, which is messenger RNA, which is what occurs after your body takes your DNA and then prepares it to create proteins. This mRNA does not have the ability to be incorporated into your body's own DNA sequence. So after the mRNA is then taken by other proteins to create the proteins that assemble the virus, and your immune system detects those proteins and then builds an immunity to it, that mRNA dissolves. It is eaten up by enzymes. And so it's not incorporated in your immune system, and it will not then produce virus for you at a later date. But the other, so two of the main vaccines that are available in the United States are mRNA vaccines. That's the Pfizer, the Moderna, and then the other vaccine, which is the Johnson & Johnson vaccine. It's not an mRNA vaccine, it's more of a traditional vaccine where you take components of the virus that are unable to cause serious illness and expose the body to it so that the body can then mount an immune response and prepare the troops for in the event that you then see the real virus. It's not that you're not going to get infected, and that's important for people to know. It's the reason why we have to continue to social distance, because you can give the infection to someone else. But the likelihood of you getting sick is really small, considering your immune system is prepared to fight the virus.
Excellent. Dr. Aluya.
Yes, I mean, I'm glad the way Dr. Salam started this, that we all show by a raise of hand those who've taken the vaccine. It does show that, if all of us who are doctors, who preserve lives, and obviously want to preserve our own lives, I'm sure none of us want to die. If the vaccines are terrible or bad, none of us will take it, and we'll be the first set of people who will come out and say, you know what, it's not safe for our community. It's not a great, but look, this is here. It's important that we do it. We go ahead and take this vaccine. I think by today, 175 million people have taken this vaccine, at least for the first shot. Just like Dr. Daniels has said, the mRNA technology and the Johnson & Johnson, and the issues that are coming up with the different strands or strains. We know right now in the United States that the most common strain that's causing an upsurge of the numbers here in the US, as of yesterday, we had 80,000 new cases, unlike what had gone down to 50 and 30 before. So there's an upsurge, and the number one culprit for that is the B117, the UK strain. And of course, we talk about the UK, the Brazilian, and the South African strain. And I tell our people, don't we think that we begin to have some strains that will develop here in the United States if we don't do this? We are. In fact, there's something coming up. I think the EEK, somebody had said something about, but it hasn't made it to the news that much yet, coming out of California. And we need to be careful about this so that as we as individuals go out to tell our families, friends, and make believers of each and every one of people who are watching right now, so that you can go on to spread the good news, so that we can save lives and livelihood. Because if we don't, I think the percentage right now, about 62% of Caucasians, as compared to about 11% still in the Black community that hasn't done this. And it's a terrible thing, because if we don't, in another 2 to 3, 4 years, when others have been vaccinated, and we right now are the most affected as in terms of death with this virus, others will be protected. And then where does that leave us as people of African descent?
Well,
That means in another 3 to 4 years, we'll be the ones dying again from this disease. So if we don't take this vaccine, other than the fact that we have the discrepancies and the disparity that's going on, we at this time will be creating our own disparities. And I say this, it's not just about vaccine hesitancy anymore. It's about vaccine deliberation. I know that a lot of our people out there, are willing to take it. Some people said, in the US, about 63% are willing to take it, but it's just that they don't understand or are really convinced well enough to take it. So if we deliberate with them and make them understand why it's important and why it's safe, I think they'll go ahead to take it. But it's something we need to do. Maybe, those of us who are Black physicians or healthcare providers should do a better job, but we've been trying. This is one platform where we're trying to do this. Maybe we'll create other platforms where we reach individuals and those who have the secular power, those in the medical field, we have to reach out to them so that, we can get them better convinced to take this vaccine.
Excellent.
Omar, if I
Excellent.
might just say
Go ahead.
something.
Go ahead. Patrick, just let me say for those, we're going to run over. I think this is so important. We're going to continue to talk about this. Go ahead, Patrick.
Yeah, I just want Dr. Salam to add a comment. We often look at outcomes in medicine as it relates to patients. With respect to COVID and feeling that's probably similar to post-traumatic stress disorder. There are guys like you, Omar, Dr. Court, Kevin, myself, who are in the operating room all the time, in the ICU all the time. Just comment on, from medical providers, how do you see the psychological impact on COVID on healthcare providers? And then the other thing that fears me is public sentiment in the long run. If the majority of us, African Americans or people of color, don't take the vaccine, and then suddenly we are the one carrying the burden of a mutant strain that's impacting society, will now public sentiment turn on us similar to what we're seeing with respect to hate crimes among Asians? I mean, these are some of the consequences or long-term effect of how we approach these things.
Well, Dr. Anderson, excellent question. And before I get into that, I want to quickly mention that as African-American physicians, we don't want to die ourselves. We don't want people to die, and we don't want Black people to die and to be very ill as a result of COVID. And we feel by, with the whole showing of hands, who's been vaccinated, they're no better ambassadors for the health of our community than us. We're products of the community. And so to address your question, Dr. Anderson, you guys are on the front lines, particularly the folks who are the critical care guys, the pulmonologists, not just the physicians, but the nurses, the respiratory therapists. And sadly enough, you faced an unstoppable tide of death. And that has a tremendous psychological impact on you on several levels. So on a human level, death could be very disturbing as human beings. And then as a healthcare provider who's charged with saving lives and mitigating illness, and in the setting of COVID, where there was just sadly enough, there was no leadership on a federal level a year ago to really stem this tide. And so you were faced with death, you were faced with the morgue trucks, you were faced with folks dying and not being able to say goodbye. And basically you were kind of limited to triage, essentially. And the impact that has on your self-worth as a provider, and you are tasked to save lives, and you're really having tremendous difficulty. I know there was a pretty high profile case of an ER doc in New York City who ended up taking her life because because of her response to this unfortunate confluence of factors. So I'm expecting to see in the wake of COVID a significant surge in mental health needs of providers, particularly those who have been facing this unstoppable tide of death in ICUs and the like. So absolutely, we are expecting that to happen. We should also remain vigilant in really responding to the needs of our colleagues, and if we observe folks struggling, and particularly look out for maladaptive ways of coping, whether it be use of substances and the like. So we should certainly be very self-aware and encourage our colleagues to get help when they need it, because sadly enough, we're starting to see the fallout from this surge in death and among frontline healthcare workers.
Dr. Salam,
Yes.
what about as far as our young men and the increased rate of suicide? Can you address that?
Yes, absolutely. Pre-COVID, there was a surge in suicide among African-American males. I think there was a 122% increase in suicides among African-American males between 1991 and 2017. And a lot of light has been shown on this particular issue. I know the Congressional Black Caucus has shown a light on this issue, and that effort was spearheaded by, I believe it was Bonnie Watson Coleman, who's a Democrat from New Jersey. And then there's the Taraji P. Henson Foundation that has shown a light on this problem as well. So if you add to that the social isolation secondary to COVID, the racial reckoning in this country as a result of what was the 846, which is now the 929, where George Floyd's life was taken, and we all bore witness to that, coupled with the fear of police violence in this country, and especially among African-American men, young guys in particular, who have a sense of a foreshortened future and may be prone to engaging in high-risk behaviors since, hey, I'm not going to be around that long anyway. And add to that the stigma of seeking mental health treatment in the Black community and the sense of vulnerability that requires when you subject yourself to treatment. So if you avoid treatment and you don't seek help, then of course there's a higher risk of suicide attempts and a potentially fatal outcome from completed suicide. So we should absolutely encourage folks to get treatment. There are tremendous resources for the African-American community. I would encourage folks to, there's actually a section on the website of the National Alliance for Mental Illness, NAMI, that's devoted to mental health resources for the Black community. The company that I helped establish, Global Health Psychiatry, and our books that are written for lay people, Mind Matters, a resource guide to psychiatry for Black communities, and the follow-up children's books, we encourage folks to really embrace that mental health literature that's written for lay people. And if someone is reporting suicidality, suicidal thoughts, don't discount that, get them help, get them to the nearest emergency room or crisis center. And finally, Psychology Today, www.Psychology Today, they have an excellent database that allows folks to access at least contact information for Black mental health providers, particularly psychologists and psychiatrists. So for those of you who reach out to me looking for an African-American provider, go to Psychology Today if you're looking for a Black therapist, psychologist, or psychiatrist.
Excellent, excellent. Any other comments on this most important topic? Okay. I just want to sum up where we went a little over time, but it's all good. I want to sum up by saying that thank you for our Facebook. I've been following it here and right beside me. Facebook has been very active, and I just appreciate all the participants from there. Note that I'm going to mention this again, that the New Jersey Medical Association, which is the Black Medical Association of New Jersey, along with the Legislative Black Caucus and clergy, they're sponsoring a community vaccine day, and that is Sunday, April 18th, 12 noon to 4 p.m. And that's in Orange, New Jersey, anywhere in the surrounding areas. If you live around Orange, New Jersey, Newark, East Orange, Irvington, Union, you're welcome, but they only have a limited amount of vaccines, so you must pre-register. go to their website, njmedicalassociation.org, and pre-register. Just hit the contact and send an email, leave your name as well as your phone number. They will get back to you and make sure that you get the vaccine. All righty, and that is April 18th, noon to 12. I'll give that website again. That's njmedicalassociation.org. Also, there are, as far as education about the vaccine and about the COVID virus from Black physicians, there is a website called A Conversation Between Us About Us. I'll say that again, A Conversation Between Us About Us. You can go, it's on YouTube as well. You have the brother Kamar Bell. He is asking questions of Black physicians to explain the vaccine as well as the virus. And it is so such an educational educational format. So go to YouTube or go to the website, A Conversation Between Us About Us. To end, I want to thank OBHealthy as usual for allowing us to use their platform so that we can bring this webinar to you. Understand that it's the second Saturday of each month at 1 o'clock. We will be here. All you have to do is go to OBHealthy, click on the bridge, click the Physicians Network, and it will bring you into the page that you can join the webinar and type your medical question in. The most important thing I can say is, do not change any aspect of your medical care until you consult your physician. They are the best and the only one that can truly take care of your medical problems appropriately. All right, until next time, listen, I just appreciate all of the doctors that are coming in and joining us every second Saturday. Thank you very much from the bottom of my heart. I just trust we can keep this going. Go to YouTube. YouTube has all of our past webinars. Please, if you go to YouTube, subscribe to us so we can continue to bring it to you that way. Until next time, I'm just going to say peace to everyone and have a safe month until we come on again. All righty. Thank you very much. Peace, everybody.
Peace.
Yeah.
Peace.
Take care now.
All right, take care.